Hey everyone, welcome to House Healthcare. It is Thursday, February 1st. So exciting. And we have Diva with us today to talk about their fiscal year 25 budget. We also have Representative Page with us from Appropriations, so please feel free to, we're happy to turn to you for questions, and a former member of the Healthcare Committee that we miss dearly. And we are going to review the budget narrative for people watching online. It is on our committee page. And I'm going to turn it over. We have Stephanie Barrett with us and Alicia Cooper with us. And Acting Commissioner Addie Stromolo with us. Welcome.
So would you like me to just start right in? I'm Stephanie Barrett, the CFO of DIVA. And what you have in front of you is a probably an 8-page document that walks through our FY25 budget proposal. The way the budget is built is we start from what was passed last year and build to our best estimates for FY25. And so the companion document to this is the ups and downs, which is also on your website. This is giving explanation to the pieces of the ups and downs and hopefully a little more digestible.
I appreciate that. Sound like ups and downs.
Yep.
Words.
So I'm going to start with our admin budget, which is where all our staffing costs and our contract costs and our operational costs lie. And then we'll move to the big budget, the program budget in DIVA.
Okay.
A lot of this is going to be very familiar from when we were in on the budget adjustment, because most of the things in that budget adjustment roll out and show up again, either in the same form or in the annualized form that for the next budget year. So,
And if you can start with a quick, what does the black numbers mean and what do the red numbers mean?
so the black numbers are an addition to what was passed last year. So if the number is black, it means it's an up. And if the number is red, it is a down compared to the budget as passed for FY24 when you left or when that got enacted at the end of June.
And so an up means we need more revenue, a down means we need more.
So the budget is spending authority. And spending authority shouldn't exceed revenue, but the budget is the spending authority side of the equation. And the revenue is what comes into our funds and what the emergency board adopted.
Great. So everyone, we're good? Okay, great.
So in our administration budget, the staffing budget, that pays for all our people and there's 378 positions and several temp positions in DIVA. The appropriations committees are used to seeing this, but there's always the rollout, the way what's called the Pay Act works. The expense of that for this year rolls out and gets annualized in the next year. And that's what you see in a majority of the staffing budget change here is the rollout of Pay Act, any internal reclassifications that have happened, the impact of that on our benefits costs, along with any other changes underlying the benefit costs. Those usually are coming down from the finance and management as well. 2 new items specifically called out in the middle of this little summary are the child care assessment. So the cost of that to the state as an employer for the employer share of the child care assessment. And also the family medical leave initiative has an assessment included. And so that if you were looking at other departments' budgets, you would see these same new expenses as a staffing cost change.
Great. And I just want to remind everyone, the family medical leave is being offered to state employees. Yes.
This is the governor's plan.
Yes.
Yeah.
And this is just the cost of staffing, not the cost of the program.
So this is the cost. The way the program is financed is a cost to the staffing charges of the departments, and that's what's reflected here. So it is the cost the program itself is not in DIVA.
So that's the cost of adding staff to operate the program.
No,
No, that's the cost of charging DIVA to have our staff be covered by
Right.
the program.
Okay.
So like me as a worker, I would have a childcare assessment come out of my paycheck.
Yeah,
I got,
As a state employee, I would have a family medical leave assessment come out of my paycheck. That's this cost. Is that
no,
accurate?
that's out of the employee's paycheck. This is out of us as the employer.
Okay, yes.
Because
well, okay.
It's your
Yeah.
portion of that
Yes.
assessment.
That's a 0.33 then?
it is the 0.33 for childcare.
Okay.
And the 0.33 for childcare is the employer share and the 0.11 is the employee share. And so that comes out of the employee share. So if you were trying to understand what the employee share is, when you look at the ups and downs, you would take a third of what our share is, the employer share, and say, and then the employee's picking up a third of that.
Are we good? So this is the employer share. Think of Diva as an employer. Okay, great, thank you.
Two other pieces that are moving in our staffing budget. We have a handful of temporary positions that are very much ongoing, that weren't properly budgeted for. They are in our rate setting and our long-term care eligibility. They're very, very good to have that capacity. And then we have one technical advisory position that we need that service. Normally temps that fill in, we don't, that's part of the whole vacancy arrangement. We don't budget for them. But these are, even though they're temporary and they're a good deal for us, we would need to cover that if those individuals left us and we had to, figure out how to cover that need in another way.
Great, okay,
I'm a little stuck.
okay.
Like, I'm back on the childcare, the chart. So, how many employees are you calculating? Is that what this is, based on a calculation of potential employees that might use the benefit?
No, it's the childcare assessment is across every employee in the state. So it's a payroll assessment.
Okay,
And so it's an assessment on, DIVA has a payroll.
right.
So that's reflected here is that 0.33%
Mhm.
against our payroll.
Okay.
That's what
For
it's,
individuals, it's just across the board to everybody.
yeah, that's why it's not the program. This is just, this is a cost to us. And it's what ends up in the end financing the program over in DCF for childcare.
And the same with FMLA.
Yeah.
That is offered to state employees.
So I'm just trying to understand 80,000 versus 190, like, how does that, where are those two numbers?
I'm sorry. So the 190 is the total gross expended. That's the cost of the 33%. In DIVA, because our expenses are Medicaid matchable or administrative expenses, mostly for staffing, it's depending on the work they're doing, but it's mostly in the 50-50 range. That expense, we're showing what the general fund share of that expense is. The cost of the childcare and family medical leave in total costs $190,000, $190,022. That's our estimate on the calculation. And of that 190, 80,630 is the general fund share of that.
So this is our typical match with Medicaid, right? Every percentage might be different, but this is general fund versus, the total.
Yeah, so we think in the total dollar, but because the budget and the state funds are really where the balancing has to happen, we always show what the state share, the general fund impact will be.
Thank you.
Stephanie, one last question, and then I do want to move on. The childcare assessment is 0.33. What's the family medical leave assessment?
I can get it for you. I don't know off the top of my head. It might be in the ups and downs, but
Okay, that'd be helpful to know. Thank you.
it's very modest. Is it
a percent like the other is, or is it?
I believe it is. Yeah.
Thank you.
The other thing that is showing up here in our staffing budget is a vacancy change. So when we built the 24 budget, we were looking at what the vacancy, position was in DIVA. Basically, at the end of 22, beginning of 23. And since then, we have done a much better job of recruitment and retention. And so our vacancy is much lower. But that means that we can't carry the vacancy target, the negative that's in the budget around vacancies at the rate it was previously at. And that's what's showing here, is bringing that vacancy rate basically down.
Because you're getting closer to fully staffed, which is very
It's
good.
a good thing. Yeah. It's a good thing. Okay. So that's the sort of the baseline of the staffing budget. And then we have two structural changes that are reflected here. I'm going to start with the quality positions first. So those quality positions were added in the central office in the FY24 budget. They were part of the 24 budget. They were moved to us in the late fall. So they were moved from the central office to DEVA, and money is being transferred for them. And of those three positions, two have already been filled. One is still under recruitment. And what you see here is the permanent movement. It annualized in FY25. And so it's the same dollar amount that was in the budget in 24, just being moved out of the central office to our budget. And then in the opposite direction is the majority of the policy unit moving out of DEVA and into the central office.
Which we heard about, I think, at a previous budget discussion. And so in AHS, we would see the flip of this. This is net neutral. Okay.
Yep. You would see the same exact numbers, just in the opposite coloring.
Great.
Then,
I had a question. You don't mind me?
Yeah, go ahead.
Yeah. The vacant positions, how long have they been vacant, you know?
so it's think of it as a time flow. Positions become vacant, we recruit, and so the vacancy target as a percentage is how across the course of the year with that happening up and down. It's not individual. There are some positions that remain vacant for the long term because they're just hard to recruit for, or we're making a decision about them.
That's kind of my point. Do
Yeah.
you keep money in for them? Or do you take the money out and say,
So
well,
that's
we can't fill it?
So that's what this reflects, is the best estimate of what we need for where we are with our total position need. Recognizing that there is a normal flow of, in a department with 378 positions, there's a normal flow of people leaving us recruiting. There's some time lag. It doesn't reflect position specific estimates.
I didn't know whether you had positions that were vacant for a very long time and you went back and reevaluated whether you even need them anymore. And therefore you take the money out, you don't have that position.
That would happen if we did that, and that would be on a position by position
Gotcha. Okay.
decision.
Okay.
The next, number two in this is our operating expenses. These are mostly what are called internal service funds. We don't control those. The rates are set centrally in what we pay for services. They're actually going down this year in total. But they're like our postage or space, the overarching HR, the overarching finance and management. Those are the workers' comp. Those are the series of internal service funds that get budgeted every year. So all the departments, if you were looking at a lot of departments, you'd see these movements in every department. And then the other piece in our operating budget to go with the policy move is that a portion, part of the way the internal service funds and the operating is done by positions. And so when the policy positions move out of us, some of their operating expense has to go with them.
And if they move in, some of it comes in.
Got it. Okay.
So moving people, you said it one more time.
So these are so some of these operating internal service funds are based on how much staff you have. And so when staff moves out of us to another place, the portion of funding that is part of those operating internal service funds has to move with them. Yeah.
That's why we see sometimes workers' comp numbers like down in the internal budgets because of that.
So that would be workers' comp. That's an insurance program. It has a rate.
Right.
So that's based on experience. So the total for the state goes up, and then what that total is gets farmed out to all the departments based on their staffing levels.
Great. what they do.
Yeah. And then this one should be very familiar to you, number 3. This is annualizing the big contract correction that you saw in the budget adjustment. The general fund is essentially, it is the same as what you saw in the budget adjustment, same reasoning. The federal fund down is a little bit less because in the budget adjustment, we took more out because of timing. This is still, we're bringing our estimate of what our need for the draw on federal funds is down. If that's not fungible, it can't go somewhere else. Other than that, it's identical to what we've done in the budget adjustment. And then number 4 is a small technical adjustment of federal funds for one portion of the Vermont Health Information Exchange project that goes out as a grant, not as a contract.
And that's no cost to the general fund.
No cost to the general fund. We just need to right size the federal fund line in the grant line for our admin budget.
Great, go ahead, Art.
Yeah, and this is fundamental, and I missed it at the very beginning of your presentation. I'm sorry to say. The black means how much it's increased
Yes,
from FY 24.
as passed.
And
Yeah.
the red is how much it's decreased.
Decreased,
Okay,
yeah.
so the gross and general fund numbers are increases over the last budget.
So yes, the general fund.
They're not
for
really a
con-
gross, it's a gross increase.
So our contract line our contracts are funded by multiple sources of funding.
Right.
General fund, a little bit of special fund, some transfer dollars.
Yeah,
And a big
you
chunk of
don't need to
federal
go
funds.
into a big explanation of that one. I'm saying in general.
So
all
in
of
general,
these.
in total, the contract line is going down, but the general fund share of that is
Yeah.
actually going up, which is very important in the budget build.
So this is up 2.9 million from the last budget.
This is up 2.9 million from the budget that you passed for FY 24
Gotcha. That's all.
Yep.
That's the main.
in the general fund.
Gotcha.
Great. So that's our administration budget. And now we'll go into our program budget. And so number 5 is a big number change. This is our caseload and utilization change. This is a result of the consensus process and what is adopted at the emergency board a couple weeks ago. This is primarily driven by the caseload change, and it reflects the fully annualized. So this is FY 25, so the budget that starts in July. We will be very close to the end of the redetermination and the unwinding process. And so FY 25 fully annualizes the impact of those projected caseload changes. And that's what's driving the significant reduction in the gross dollars down. And the mix of which Medicaid eligibility groups are going down, and a few are going up, because there's not just movement in and out of the program. We budget by the Medicaid eligibility groups and their per member per month. There's also movement within members move from one category to the other, children aging into adults, folks moving out of a general adult category into an MABD category. So that movement happens, or into a dual category. So that movement's also happening at the same time that it's in and out of the program. And what you see here is the reflection of all those movements under that consensus process of what we think the steady state, given the current policy context, what that looks like.
Okay, and so a couple questions or a couple comments too. So we will come back to, potentially if we have time at the end, we could maybe get a little bit of an update on the Medicaid unwind, but we will schedule time to hear specifically about the Medicaid unwind. So that's what this is. Part of that is what's in here.
And folks with the budget book or online, the pullouts in the budget book, if you're inclined to look at sheets with lots of numbers on them, you can see what those individual estimates are.
Great.
Okay. If you're.
And a question, and we, just so you know, we love the budget book. So I know you all don't like to print it much anymore, but we love it. So thank you for doing it. The question I have is, when does the enhanced FMAP stop for the fact that we were keeping people on Medicaid through the pandemic?
It has stopped.
It has stopped. Okay, it did stop. Okay, great. Not great, but good. Any questions on this section? Okay, great.
So section number 6 is also familiar from the budget adjustment. This is the buy-in and current Medicare savings plan budget. So this is current policy.
Yes, not the policy that we have in front of us as a tentative bill. Thank you for that.
And this increase is reflecting the annualized estimate of the impacts of the premium increases that have taken effect in January this year. So it's a much smaller number when you saw it in budget adjustment.
Yep.
And now it's the annualized number for the current construct.
I just want to read this. So it's the annualization of the premiums. Is there change in numbers that are coming in or out of? Is that reflected in this data?
So it is reflected in our, the buy-in, this works a little differently than the way we pay claims for our regular enrolled folk. We get a bill from CMS on member months.
Okay.
And so we do in our estimate, look at that. It's a very modest change.
Okay. Perfect. Thank you.
In our projection on that.
Okay.
Number 7 is the clawback. That's 100% general fund. And that is the fully annualized estimate for that significant increase that's projected for clawback. Clawback is going back almost 20 years. The savings is supposed to reflect the savings to the states from when the federal government turned on Medicare Part D, the pharmacy benefit. That was, in fact, saving states money in their Medicare program for their dual population. And part of the financing of that benefit, that federal benefit, is these clawbacks from the state. And they do a calculation based on population and drug prices, and FFIS tracks that and lets us know what the percentage increase is likely to be. And that's another one where we just get a bill from the federal government on a quarterly basis.
Right. Okay.
Does anyone check that bill? Does anyone verify that it's accurate?
So we.
Or just say no?
We wish our.
Saying no might
Yeah.
result in a different action.
No, but you can verify it.
Oh, we look at it, we try and understand it, but in terms of the underlying calculation,
Yeah.
for
obvious.
consistent, we don't have a way to say, well, we don't have, what you think the increase in drug prices have been.
Yeah.
That wouldn't be part of what we do, but. The 8 is the family planning services. This is just a net neutral move. It's the same move you saw in budget adjustment. It's now being paid out of the DEVA budget. It's now being paid out of the DEVA budget. So you'd see a corresponding down in the health department's budget through the MMIS system. Number 9 are the safety net investments. That's not a change at all. That's simply a move internally that we were carrying it up in the global commitment, but it needs to be down in the state only. We do match it because it's emergency services usually, but it needs to be carried as an investment, as a waiver investment in the right line. So that's all that's happening with that line. It's not, we're not moving it up or down in total. We're simply putting it in the right bucket for our accounting.
So we learned a little bit about investments this week. Global commitment investments. Is that what you're meaning when you say investments? It's one of those 8.
It is a waiver investment.
Okay.
Yeah. It is, we do get to match these dollars.
Okay. Okay.
Number 10 should be also familiar from the budget adjustment. These are the breast pump supplies, fully annualized. Number 11 is also familiar from the budget adjustment, another fully annualized cost of the 4.6% Medicare Economic Index adjustment for FQHCs and rural health centers. Number 12 are the hospice rates, which were also in budget adjustment, fully annualized, bringing those up to the minimum that they need to be in compliance.
Yep.
And number 13 was also in the budget adjustment. And this one is not a change in a cost. This is, we pay the Brattleboro Retreat under an alternative payment method. It doesn't change that total that's budgeted for that alternative payment method, but we are looking at the mix of patients that are being served in the retreat. And this is also a bucketing issue. We can only draw match if they're on, folks under 60 days. So if the patient mix, which is forensic or longer stay, what this is reflecting is that mix is different than what we thought when we built the budget. And so even though the total to the retreat is not changing, but the internal cost to us is changing by which funding source it's coming out of. And we're saying more has to come out of the general fund than previously thought.
But it is still all reflective as people who have Medicaid insurance being treated. We're not paying for costs associated with other people there who have commercial insurance.
They are paying their commercial insurance, or Medicare is paying first.
Okay.
And if they are there long enough that they exhaust, then we would start to pick up.
Okay.
Number 14. So this is the child care payroll tax again. This is a very small amount for the children's personal care services. And so that's a program where the family directs and hires the care service, and a payroll intermediary pays. And so essentially that the family and our program is the employer in that case. And so this is picking up for that piece of care services, the employment assessment, the payroll assessment for this program. And so this is the 33%. So the folks that are employees providing the care would have about a third of this as the cost coming out of their paycheck. And if you are looking at Dale's budget, you will see this for the other personal care services it's a much bigger program.
Okay.
Graduate medical education. This program it's a allowed program under Medicaid to support graduate medical education. Last year, there was a significant increase. It's driven by a 3-pronged calculation on what the state can spend on this. The match for this does not come from the state. It actually comes from the university. And the calculation is showing that this can go up by $7.1 million. And so we need the spending authority in the budget to do it. And this is the unusual one that has a federal draw without an immediate general fund impact.
Do you know where the money goes? Does it go to the graduate courses like the schools, or does it go directly to students?
So it pays for residency slots and supervision, and also for we actually
It's probably in the budget book because we've talked about this before.
I remembered. I just couldn't
Yeah.
remember where the money directly went. You can get it to us later. That's great.
So it's also meant to compensate for the difference between commercial and Medicaid payments for in the setting in the
Residency.
yeah. And it's a formula-based calculation to cover additional patient care costs by teaching hospitals over non-teaching hospitals. So, and then we also, the way this works is we enter into an agreement with UVMMC each year around this with some, direction and things that we'd like them to prioritize in the programs. And so on page 52 in the book provides a couple pages of more
Great. Thank you for that.
more explanation on the GMA. Number 16 is a increase in the percentage of the rate paid to out-of-state hospitals in comparison to in-state hospitals. That's a policy decision going forward. And then number 17 is a new item.
Okay.
And this is the psychiatric residential treatment facility. This is the amount of dollars that you see here is a partial year estimate. So the work to bring this capacity online is happening right now. It's the contract is being supervised by the central office, but led by DMH and DCF.
Is this the youth and patient beds in Southern Vermont?
This is actually going to be at the retreat. This is a
Different.
very specific
Okay.
Medicaid allowed setting.
Okay.
And so this will potentially bring on 15 or maybe 16 beds to serve youth in the custody of DCF, mental health, and Dale. The programmatic scope of this, I would direct you to those other departments working on that. But DIVA will be the payer. It will be paid out through our claims system
Okay.
in the end, and we're involved in terms of technical and legal assistance when we get to the rate setting and that part of the negotiation. And just to be very clear, you may see a need for a budget adjustment depending on when this gets up, how quickly it comes to scale. You will definitely see it be annualized in the next budget. But this is the main new piece in the DIVA budget on a baseline basis in the base budget.
So we have DMH coming in tomorrow, so we'll ask them to talk to us about the policy behind this.
Okay,
Divas.
that was my question. Did we talk about this?
Yep, we can, I don't remember talking about
I
this.
don't
That doesn't
remember.
mean we haven't.
Yeah.
So we'll ask DMH and we've invited AHS to come in as well. So let's not pepper Diva with these questions policy wise.
Yeah.
That work. Yeah.
And then we have one significant one-time item in the budget, which is, we talked about the global payment program a little bit when we ran on budget adjustment. It didn't have dollars in it. We were doing a very modest internal independent practices version of this right now that started in January. This funding allows us to do that pilot program in FY25 for some of the hospitals in the state, which would be, the program is taking the portion of their Medicaid payments that don't flow right now through the all-payer model, the ACO, and doing those in a fully reconciled, so no very low risk pilot payment to see how our systems work, how it looks to when you put the two together, the existing all-payer model and this pilot program, and you have basically the global payment for the hospitals for the pieces that are included as a test.
Right. So I'll remind everyone, we talked about this during budget adjustment. So if the Medicaid has a all payer, I'm not saying the right words today, with Medicaid insured that are attributed to the ACO. And so that's that bucket. Then there are people who are not attributed. They may come on and off. Medicaid is a flowing to get on and off. And so this group has always been fee for service. Correct me if I'm wrong. And so now DIVA, as part of preparations potentially for the AHEAD model, is looking at that population to see how we can make it as an all-payer contract as well. Do I have that right? Okay. Did you want to add anything else?
Oh, I think that was a great summary.
Okay. So, couple questions. I have a question. Do we know in this budget number, how many attributed lives are you putting into this program? And what is that based on, since people flow in and out?
It's a fantastic question. And I think the benefit of starting to look at this global payment program construct is that we're moving a little bit away from the notion of attribution. So this estimate is what it would take to pay. This estimate is specifically what it would mean to kind of switch on prospective payments and simultaneously pay for the claims that are running from prior dates of service. So that's all that this estimate is associated with. The program itself would effectively make it possible for Medicaid to pay more fixed monthly payments to participating hospitals. And those payments would be for any other Medicaid members who are not attributed. And so I think the number might be a little bit of a moving target while our population is continuing to go through the redetermination process. But it's essentially designed to be anybody else who isn't attributed, whether they are known to us now or whether they, are new to Medicaid in the next, 6 to 8 months. Account for that.
Okay, so we have Topper, we have Art.
It's UVM, one of the hospitals.
UVM is one of the hospitals that is interested in participating in the pilot year.
Art?
When you say attributed, what do you mean by that? I'm trying to understand what we're doing.
Sure. So in our ACO model, which has been operating for several years now, we use an attribution methodology, which essentially looks at where a member has had their services historically and says, it looks like that's where your primary care relationship is. And if your primary care relationship is with a provider that's participating in the ACO network, then you are considered attributed to the ACO for their taking accountability for the cost and quality of your care. We've looked at the definition of attribution over time through our Medicaid program, and we've made some adjustments to it over the years so that it's not exclusive to the primary care relationship. But as Chair Houghton described, there are always some limitations to that attribution process because it happens at a point in time before the start of a calendar year. And then the Medicaid eligibility can change throughout the course of a year, and it won't necessarily tie back to that original attribution.
In 17 and 18, the numbers last thing were 0, right? Fiscal year. There
So 17
there was nothing.
Yes,
So
17 is
these
new.
numbers would be. Okay.
Yes.
Yeah, gotcha.
And the 18 is one time. It doesn't build the base. That is simply to cover
Right.
the timing
Right.
differential.
Right. Yep.
So we have another question, Lisa.
Maybe I missed it, I'm not sure. So you had asked like how many you're anticipating. And so how'd you come up with 9 million? Oh, we 79. We don't have any idea.
Right. No, we looked at actually the claims for the past 2 years for several hospitals that have expressed interest and looked at that over time for the portion that has been paid out outside of the all payer model and said, over that period of time, month to month, it's just overlap with claims. That's how we actually have a pretty high degree of confidence in that number because of the past history that we have.
That makes more sense. I'm like,
How'd you get there?
Lori,
Yes.
a quick ask. You mentioned UVM's interested. Can you share which other hospitals might be interested?
Sure. The other hospitals in the UVM Health Network are also interested. So that would be Central Vermont Medical Center and Porter. And then we also have heard interest from Rutland Regional Medical Center and from Northeastern Vermont Regional Hospital.
Thank you.
And this is one-time money.
This is one time. This is simply a timing gap coverage. Because we will have to continue to pay the claims that run out for 6 to 8, 10 weeks at the same time that we are making the prospective payment.
So, and I apologize if this is in the book. Do you have in the very first page, you have the 25 summary. Department across all funds and all appropriations results in a decrease of 20 million. I take it that's gross? Do you have the general fund amount?
Sure, it's actually right at the bottom of the.
Is it?
Ups and downs, and the general fund amount is actually an up of about $13 million, 13.232. If you're interested in these very tiny spreadsheets, the bottom line in the bottom block is the increment up. And those are the general funds that are directly appropriated to us. We're always a little complicated because the general funds that are associated with the global commitment moves are actually up in the central office. And we can, with anyone that's interested, we can walk through those.
I just wondered, 13 million general fund up.
Yep.
What is that percent increase over last year in general fund?
In general fund, it's significant. It's about a 13% increase.
2%.
Can you tell me what line you're looking at? I'm sorry.
So I'm in the ups and downs, and you go to the very bottom of it.
I saw 28 million and then I thought I heard you say 13, so I got confused.
So if you go past all the blocks of appropriations down to the sort of blue block at the very bottom.
Just the first pull out in the book.
No.
No, well, it could be the second page.
Page 61 is on that pullout, page 61.
Or if you're looking at the ups and downs online, you go to the very end of it. And there's a line that's totaled FY 25 GovRec. And then there's a total increases and decreases. And it's that total increases and decreases is where you will see that.
That's the 28 million you're talking about. That's 28 million. So I just want to get the number on.
Oh, okay, so that's, that does include the pieces that are in the central office. This is the piece that includes just what's to us. It's complicated because of the way the split happens.
The general fund is the 13 million.
Yes.
Got it.
13 million.
Not located. Thank
Yeah.
you.
Okay.
Melanie?
So this is my first monthly budget, so I'm just gonna put that out there. I do have a question, and if it's not for you, then you can put me someplace else. But it's my understanding that you all regulate and do the reimbursements for non-emergency medical transportation. And it's an entitlement, so we have to do it. We're hearing from providers that they don't have enough funding, and the way that the contracts are, that they're at a shortfall, and we didn't get a BAA adjustment, I don't believe. So curious what you budgeted in this budget for that, and are there ways to look at how we're funding this?
So just to give you, there are ways to look at how we're funding this. The base budget is essentially the same as the 24 budget.
So
It's level funded. We do have lots of conversations with BPTA, who is our state broker. And we do this, the way we procure those services is through an agreement. We are working on an extension right now because that agreement ends at the end of June. And the conversations, there was a report that's gone to the transportation committees, but as we've had several conversations with BPTA. Their first quarter of the year was looking good. It's changed. Their outlook has changed, we understand. And so we expect to have continuing conversations around that. The fact that it's not in the BAA and what they look like for the current year and the next year, the budget does offer an opportunity. If there's a need, you can make things effective on passage, but that,
So I was just curious as to why it was level funded for this year, if there's already like that level of.
because it's actually a brand new known in the last few weeks as opposed to when the budget was being built in the fall. Their first quarter was looking like they will probably be able to live with that.
So there's no way to work on.
So we can,
Okay, I just.
yeah, let me pick up on this. So Melanie, do you have a number? Has anyone told you how much their overall?
No, I
think we have to still work through
yeah,
that.
there's pieces. I know that just the one in my area, they're already in the red, $150,000.
Okay.
And they didn't get an adjustment. So I don't know what it is across the state, but it would be good to know.
So I think what we would like to see in order to determine if we want to put it in our budget recommend to appropriation is to be able to bring them up to cover their costs. What would that take? And is that something you're working on currently that you could get back to us?
Okay, we can get back to you. The covering costs versus, we do this through a rate structure. And so we want to look at some alternatives that, because different agencies in the system have different types of impacts. And are there structures that we can look at that that have a payment structure that get at that better than a sort of a full cost coverage, which is not the sort of, it's not the way that the agreement works right now.
Okay. And so what is your timeline on looking at those options?
It's over the next several weeks.
So we will have them in and we will ask them for what their budget proposal is. And so we'll want to find a way to marry the two and determine then if we put it as a priority on our list. So thank you. Are there other questions right now?
There is one piece of language in the governor's recommended
Oh,
budget.
Yes, please direct us there.
And I didn't send over the language. It's up on the appropriations website. But if you are, and the appropriations committee normally farms out the language.
Yeah, they do. They haven't yet.
Yeah. But it is in section E 307, I believe. And it's a technical change related to Medicaid recovery of estates, and a probate court timing change that was done several years ago. And right now we have experience where the probate courts have made decisions where we cannot recover, even though we're required to. And this is and it has to do with timing of when a claimant comes to make that claim.
Okay.
And so savvier estates could wait out the clock and avoid it, and less savvy might. It presents a concern to us, and so we have proposed a solution in the language that you see before you. And I just wanted to make you aware of that. We also know that there was some budget adjustment language that was initially in from the House committee that came out on the House floor. And we want to make sure if those are being considered, they're being considered all together.
Okay.
So that, the policy pieces around Medicaid estate recovery are, they work together in their various phases.
Language before us, I'm sorry.
It's so.
But that's not before us. I'm just.
So what happens?
Just
Hold on. So what happens is language, the governor, when he does his budget, he submits a packet of language. That right now is on the appropriations website.
I got it.
Appropriations will slice it up and send us what language we have to respond to. And so we do not have that in front of us right now.
Language before us, and I just thought I lost it.
And so we can find it on the appropriations website, and we can also wait until appropriation sends it to us. And we also have Melanie who's covering the DEVA budget. So she will make a note to look at
I'm
that.
looking at the appropriations website and maybe someone could parse it later.
You can also look at the Joint Fiscal Office website, which makes it a lot easier.
Thank you.
Thank you.
That's so simple.
I have and I don't know if this is the time to ask questions about.
Absolutely.
It
Yep.
is, okay. It looks like about a 12%, 13%
Yep.
increase.
On the general fund alone, even though.
General fund alone, yeah.
Even though the total is down.
The total is down. I see that, but
Yeah.
my concentration really is because that's where the taxpayer funds
Yeah.
is there. We're doing the redetermination for Medicaid. And in my thought process, I'm thinking that should save us money. And I'm trying to figure out where the bulk of this change comes now. I know we just went through it, but I'm trying to get my head around that big of an increase.
Okay.
And it probably is very justified, but it's
Okay.
a lot of money.
So I can summarize it for you.
Yeah, that's what I'd
Okay.
like.
6 million of it is in our admin budget of the general fund. 3 on the staffing and almost 3 on the contracts.
And
That's
that's because,
the pieces we went through here.
yeah,
It's,
Number 1, 2,
actually, it's not 6, I'm sorry. It's 4.4. 4.4 million of it is in our admin budget. I'm sorry, I read the wrong number. So it's 1.4 on our staffing budget and 2.9 on our contracts. So
yeah,
that's 4.4 of the 13.
all right.
2.6 is in our buy-in budget. Those uncontrollable costs from the federal government that we don't control. And and another 3 billion of it is clawback. So 5.6 are just on those federal pieces alone.
Is there anything we can do about this stuff?
Federal pieces.
I know the Fed you can't, but how about the administration? What's, you know,
So administration is staffing. So 378 positions. And then,
why is it that much more than last year?
So we have to fund the Pay Act, the cost of the increase that is agreed to in the labor agreement.
Okay,
And then we also, as we explained, have a significant increase because our vacancy is lower. Those are the two biggest drivers there. The other smaller drivers are a little less,
probably healthcare.
And then the bigger part of that, the 2.9 that is contracts, that is right sizing our contract budget that has been off for several years. And so that's the same number that you have approved in the budget adjustment. And I know it's painful because it's general fund. Even though our total contract cost is down, it is the way, the portions of those contracts that can be drawn on federal dollars versus the portion that has to be paid for on state dollars. That's what's being corrected here in the contract line.
And can you just maybe to remind us what some of those contracts are and what they do?
So the big one is Gainwell is our fiscal agent. That has an annual budget in its component pieces. Our call center is up for RFP. We have Optum, which helps us, run our system for the for data and for HeyU for the enrollment pieces. Those are some of the big ones. And then there are 75 to 90 contracts. We have, several smaller contracts through the blueprint. We have quality assurance contracts. We have technical assistance contracts in a variety of ways, but it's driven mostly in the bigger ones where the general fund share of them was held constant for reasons I don't understand for several years. And it created a problem for us in closing out the year where you have to seek transfers from other departments, other help from the central office to close the year because we, in addition to that, also pushed bills forward. And that's just not, you want a budget where the best estimate of the cost is, and that's what's reflected in that contract ask.
And I think we have to remember, you are an insurance, I'm going to say company, but you're not, right? You provide insurance to a very large segment of our population. And with that comes a call center, so you can take calls from your members. I'm going to call them insured members. And there's IT and infrastructure that's required to run Vermont Health Connect and to make sure people have access to what they need to have access to in order to be insured.
And we have to process our claims.
And you have that's probably the biggest one. So those.
But we've been doing that right along. We've been doing that, correct?
We have been doing that, but what I just mentioned at the close of FY23, we just didn't have our budget in this line item correct.
Right.
And that's what you're feeling. And I have empathy for that because it's painful to ask for.
It is painful, right? You'd rather go to, other things, but. Alyssa.
So I'm just looking at sort of what's not in here. Other than the two categories of rates that you have to raise because they're federally mandated. There's no rate increases at all. And so I'm looking at your caseload utilization and frankly, your per member per month is going down.
And actually our caseload is going down, our enrollment is going down.
No, yeah, I understand your caseload's going down, but so is your per member per month spend, which means you're not. No, it's all of them. There's every category. Anyways, I guess what I'm saying is that we know that traditionally Medicaid has lower rates. Are there any rates you considered?
Or are there any rates that are going down that are not in the documentation?
So
There are no decreases to rates that are not included in the documentation. All of our annual updates that were performed for January were considered budget neutral updates and did not represent an up or a down. And in terms of sort of an analysis of rates, we do look at all of our different rate methodologies on an annual basis. But the consideration and prioritization of what rates are to put forward for updates in the budget process happens through the agency. And so DEVA puts forward things for consideration. DMH, Dale, DCF, all of the other departments with programs put forward rates for consideration. And then at the agency level, knowing the amount that the agency may have to work with, there's prioritization that happens among the departments.
Would DEVA put any suggested rate increases forward to AHS?
I think all of the departments considered options.
Do we know which rates those were
I think
that was requested?
not having been specifically in the agency level conversations about rates, I don't know that either of us are in a position to comment.
But on the PMPMs, which you're seeing go down from 24 BAA, I think, perhaps.
Also from 2024 as passed.
Okay, so we can talk through those because some of those have to do with movements internally across the, because we do spend a lot of time on that internally. But
So more directly, can you provide this committee, and if you can't, but can you provide this committee the suggestions you sent to the agency on what you would like to see for rate increases?
We can consult with the agency on that.
Thank you.
thank you.
All right, anything else? So, Daisy and Melanie are our budget liaisons to appropriations, so you may hear from them. We will, if we all have additional questions, we will make sure we funnel it through them, so you're not hearing from 11 of us. So you might hear more, and I think we wanted to come back to transportation. We'll come back, not with you, but we'll come back on the language request, and then we will come back. We'll ask DMH and AHS about number 18 it was, which was the pediatric residential treatment.
Oh, 18.
Yep.
17. Yep.
Yeah, but we'll digest this and let you know if we have any questions. Thank you so much. We appreciate you coming in. Thank you, Addie.
Wow, what a big budget you all have.
That's a lot. And we can go, well, hold on. We are starting promptly at 10.